Time we'll move to our next presentation, and we'd like to welcome Dr. Ajit Mullasari to present on purpose-built stents for left main bifurcation PCI addressing distal vessel mismatch issue.
In diameter, here this 4.3. So clearly we need a 3.5 stent plus in the circumflex. We need a 4.5 maybe in the left main. So that's the plan in my head as I start doing this case. The next thing what I do is I go into the balloon, predilate the LAD and do the left main LAD and the left main circ with the two balloons, and then we stent into the circumflex with a minimum protrusion. This is a DK crush. So we put a minimal protrusion to the distal left main, and that's very important that you should not protrude too much in a DK crush. You have a balloon in the LAD, as you can see very clearly. The balloon is sitting here, so you can crush that lesion there. You crush it using a 3.5 NC Trek, and then you recross proximally with the hydrophilic wire, and we dilate with a 1.5 balloon, and then post-dilate with a 3.012 and a left main LAD with a 3.5 NC Trek. We do the first kissing, and then we stent the left main to the LAD with a 3.5 into 2 synergies. The IVUS, as you saw, had an LAD at 3, the distal stent was patent, and we know the synergy will go up to 3.5, will go up to 4.5 for sure, and 4.6 is what you have. And then you do the port, and follow it by the balloon dilatation. You do the port, you finish the port, you circ rewire, you do circ dilatation again, you do the LAD dilatation, the second kiss, and then you finally finish with the last pot. So this is a sequence of DK crush which you should do stepwise in every patient who has a DK crush. Now the question is, we did all this. This is the diameters we got post-procedure, and you have a pullback from both IVUS, from the circumflex and LAD, looking good. I don't think there's a problem. You got a left main diameter, which is a distal stent diameter of 3.8, the left main at 4.75 from the circ, and the mean stent area is a left main 15, LAD is 10, circumflex is 9, and the POC is 10. Excellent date, excellent result So why do we need anything further? The question is that you were lucky that you had a 3.5 circ, a 3.0 LAD, and a 4.7 left main. Say you had a 6 left main, what would you do? That's where the issue starts, when you have a lesion which has 2. And that is where things will change, and that is where you need better stents for the whole thing. If you look at the Excel data, acute stent deformation occurred in 6.55% of cases. And if you had a stent deformation, patients did badly. You had a double MACE if you had stent deformation. And when does stent deformation occur? When you overdilate stents, which cannot be dilated. When you shorten stents, when you overdilate. And when you are trying to push the stent up or push the stent in, and you deform the proximal part of the stent with the longitudinal stent deformation. So these are the 3 areas where you need to be careful when you're doing left main stenting. So clearly we need to not have a stent deformation from the Excel data. You will get double bad outcomes in terms of MACE. Now this is the new kid on the block, and just want to know, none of us, I have not used it, but some of people in India have used it. But what I want to ask you to look at very carefully is the design. It's got, first thing, a strong radial strength related to 2 issues. One is a 12-peak design with short struts. This makes the radial strength very, very good. There are 4 connectors on the proximal segment. again makes radial strength very, very good. There's a 4 micromillimeter abluminable bioabsorbable polymer, which makes the drug elution characteristics pretty good. And there is 3 connectors throughout the body. 4 connectors proximal, 3 connectors distal, 12-peak design with a 4 micromillimeter abluminable bioabsorbable polymer. So it gives you 2 advantages: good axial because of the struts and good radial because of the connectors. And it's extremely good when you're dealing with left main and proximal LAD. The other big advantage of this is this. You saw the synergy being used in the last case. I had a push of a 3.5, I could push it to 4.25, a little bit of push, I can get 4.5. With a Megatron, a 3.5 easily goes to 5, and with some push, I can get it to 6. So if I have a really roomy left main, I can't put the synergy, because the synergy will go only up to 5. And if you try to push it up to 6, you're going to break the strut, and you're going to get a deformation, which is a problem. So this stent gives you that advantage of additional connectors in the proximal segments, which gives you the strength both radially and in axial length, in axial strength. The other thing, the stent pattern is maintained. Many times when you open the stent with high pressure or high dilatation, the stent looks deformed on the IVUS or the OCT. Here the design remains exactly the same, because you can see the 9-peak design on a prototype on the top and a 12-peak design on the bottom, and the same diameters, 3.5 and a 5, and you can see how the Synergy Megatron performs in terms of the pictures. Very, very clean, no deformity in the pattern, no tissue prolapse. And this is something, when you make the stent roomier, the struts move aside, you'll get tissue prolapse. That doesn't happen here. So clearly the 12-peak design gives you a much better strength to avoid prolapse. So these are the various side branch expansion criteria. We can see the access which is there with all of these are good stents which are currently available. And I think that this is the great part of these new stents, that you're getting access, strength, axial, radial, and strut design maintained through the artery. I think it's a purpose-built stent for the left main, and this is what you're going to get now with the best-in-class axial and radial strength, uniform scaffolding, good overexpansion. We can get up to 6 very quickly, and I'm not saying this is the only stent. We've got other great stents, the Sierra in the market, we've got the Nagomi in the market. All of them give you this thing. And most importantly, it has a platinum chromium on top of it, so I can see it in the cath lab very, very easily to prevent longitudinal deformation. Your guide will get sucked in when you're doing these kissings in DK Crush, and you will be very, very careful with your guide, because the guide is going to hit the stent and you're going to get a longitudinal deformation. So I think that to conclude, what I would like to say is that here we have a great stent which gives you a strength, a design, and increased expansion overall ability to give you a great. Finally, we need to also understand the trackability of these stents. These stents are good at bends. They can have because of their bending, they can, you need to be very, very clear that you don't lose acute lumen loss, because some of these stents, when you track around, you can lose lumen when because of recoil. I think that this, again, I've told you, and I think that this is a good delivery system. I've used it in very tortuous radial arteries with no backup, and these stents go very, very nicely around these bends. So I think this is another interesting innovation of laser cut hypotubes, which makes the stent very, very conformable and flexible with pushability. So I'd like to conclude by this slide by saying that we are getting these stents which are trackable, which are optimal, which are strong, both radially and axially. And the deformation of the stents in the left main, which is in Excel, showed the outcome differences of MACE by double will come down with these new left main specific purpose-built stents. Thank you very much.